Hello, my name is David Villar, a professor of pharmacology at the University of Antioquia in Colombia, and welcome to this presentation on the use of fentanyl in dogs and cats. On this broadcast, we're only going to address some of the pharmacokinetic aspects of the different forms of delivering fentanyl. If you don't happen to be familiar with them and you plan to use fentanyl in your therapeutic protocols, I hope you will find them useful. We should start saying that fentanyl has been used to alleviate pain in chronic diseases in humans since the early 1960s when it was originally synthesized, and in an extra-label manner it's also been used for the management of surgical and severe intractable pain in dogs and cats. It's been used as an adjunct drug to attain a state of balanced anesthesia, and for those of you that are already familiar with it, you'll see that the concentrations of most anesthetics that you will need throughout the surgical procedure is much lower when you use it in combination with fentanyl. It has a pretty strong sparing effect with anesthetics like isoflurane. Here are some of the different forms of delivering. We have the transdermal patches, the topical solutions, and the constant intravenous infusions. And if we say a few things about the properties of fentanyl, we should probably highlight its potency, which is 100-fold greater than morphine. So we're only going to use micrograms per kilogram as opposed to milligrams per kilogram. And potency is also an important factor if we want to deliver any drug through the skin. And in this respect, fentanyl would be a much better candidate for transdermal delivery compared with morphine, because a much slower surface area is needed to administer an effective dose. And just to illustrate an example, let's assume that both drugs were equally absorbed, which is not the case because morphine is not very lipophilic. For a 10 kilogram dog, you would need a surface area of 1.2 square centimeters to provide an effective dose of fentanyl, as compared to 60 square centimeters for morphine. Another property would be how lipophilic it is, and if we use the octanol water partition coefficient as an indicator of water solubility, we'll see that it's more than 1,000-fold more lipophilic than morphine, and the consequences of that is it will penetrate the central nervous system very fast, so the onset of action will be quick, but just as quick it's going to come out of the brain, so it's going to be very short-lived. And if we expand on the implications of being such a lipophilic molecule, and I'm going to use this hydraulic model to illustrate how fentanyl moves through the body. If I gave an IV bolus of the drug to an animal, it would first find its way throughout all the systemic circulation, which we could represent as this central bucket in this model. And as you can see, that central bucket is connected to a small one by a large diameter pipe, so it's going to fill up very quickly with fentanyl, and we could say that this bucket is the brain that receives a pretty large blood flow, but because it's very small, the concentrations are going to equilibrate very quickly with those in blood. In other words, those going in are going to equal those going out in just a matter of a few minutes. And as you can see, that central bucket is also connected with a larger one by a smaller diameter pipe. So it's not going to receive as much blood flow, but it holds a lot more of the drug. So it's going to take a lot longer in hours to fill up. Now, we could call that the adipose tissue, but if you think about it, the skeletal muscle receives a much greater supply of blood and might be just as big as the adipose tissue. So we should probably say that the skeletal muscle would come first and then the adipose tissue second. And at least during the early stages of any infusion, penetration really in the skeletal muscle would definitely contribute more to the redistribution of fentanyl out of the brain. If we were to plot what is taking place on a graph that we have the concentrations in the y-axis as a percentage of the dose that was given and time in the x-axis,
we could see that the concentrations in blood are going to drop very quickly, and at the same time they tend to rise in the brain to reach a peak in which the number of molecules going in equal those going out, and then it falls very quickly. Now, the concentration in blood at the time when we reach that peak in the brain is what we would like to attain when we talk about achieving a steady state concentrations in plasma so that we have therapeutic levels in the brain. But as you can see, because the concentrations in blood continue to drop because we only gave a single dose, and the reason being is that the body is filling up the other buckets, the skeletal muscle and the adipose tissue. This is why we say that fentanyl has a very rapid onset of action, but it has a very rapid redistribution because it goes to other places outside of the brain. Now, you could all be asking yourself what happens to the elimination from this hypothetical model. And we could see on that graph there is a faucet on the lower part of the central bucket. In terms of the time that fentanyl stays in the brain, really redistribution plays a much greater role than the elimination out of the body. On the graph on the lower left, we have represented on a logarithmic scale what happens in plasma over time. And we could divide that curve in two straight lines. The first one that has a much steeper slope, and a second one which is a slower slope. Now, from a kinetic standpoint, that first part is typically the distribution phase, and for most drugs that is usually just a few minutes. But as you can see here, for fentanyl it takes at least 4 hours with a half-life of 45 minutes, and that's why we say that fentanyl is very slowly distributed. It takes a long time to reach all the compartments and equilibrate everywhere it can go in the body. There is one other conclusion we can get out of this graph. If you were to carry that elimination line all the way to time 0, and you divide the dose that was given by the concentration at plasma at that time 0, when you would assume that all the dose would have instantly distributed throughout the body, you could come up with a very high volume of distribution of 10 liters per kilogram, which is huge, and basically is telling you that fentanyl does not like to stay in circulation and just rather find its way anywhere else, any other compartment in the body, rather than staying in plasma. And finally, one other implication of being so lipophilic, and that we can use to our advantage, is that it penetrates the skin very well. So let's say a few things about the forms of delivery, starting with the transdermal human patches. When you apply them directly in contact with the skin, they're supposed to deliver a constant amount of fentanyl per hour, and in this picture we have an example of a patch that delivers 25 micrograms per hour. And considering that it takes 4 half-lives to achieve about 94% of a steady state concentrations, and we said that the half-life of fentanyl in blood was 9 hours, you will not see that the concentrations start plateauing until you have put the patch in place for at least 24 hours. And after that point, you can see that the concentrations stay relatively constant for another 48 hours until you remove the patch, and then they start to fall again. Now, the takeaway message from this is that you will have a delay in the onset of action of at least 16 to 24 hours if you are aiming to have at least 1 nanogram per mil of fentanyl in plasma, which has been therapeutic levels reported for humans. Obviously, you can always provide a loading dose that will put you above the mark of 1 nanogram per mil. That way you will have analgesia starting immediately and don't have to wait for the concentrations to rise. If we say a few special notes on the patches, we should always mention that there are species differences in drug absorption. And for dogs, the human patches don't seem to deliver as they do in humans, about 74%. In cats, apparently the absorption is even lower. It's been reported to be 36%. And obviously you're always going to have conditions that are going to alter the release of the drug. We should mention the thickness of the skin and any diseases that alter the permeability of the stratum corneum, a lower body temperature, and hydration of the skin. Obviously, if an animal is dehydrated, the skin is going to be less perfused, and if there is no blood getting to the skin, there is no going to be any absorption. You can probably gather how important it is for that patch to stay in good contact with the skin. Otherwise, the absorption might be very erratic or unpredictable. So we're just going to play a short video clip that illustrates really nicely how that patch should be placed on the dorsal neck of a dog.
The patient is placed in sternal recumbency. The typical locations for fentanyl patch application are the dorsum of the neck or back for dogs and the lateral thorax for cats. Hair over the chosen placement area is clipped for site preparation. Equipment needed when placing a fentanyl patch for transdermal opioid delivery include a duragesic patch and saline solution in gauze squares for preparation of the skin. Latex gloves should be worn and an adhesive bandage is recommended for securing the patch. Water or saline can be used to clean the skin before patch application. Alcohol and detergent-containing soaps should not be used since they may alter epidermal lipid content and absorption. The skin must be dried before the patch is applied. Gloves should always be worn when handling a fentanyl patch and immediately discarded following patch application. The occlusive backing of the fentanyl patch is then peeled off, and the patch is carefully pressed onto the skin. Covering the patch with an adhesive bandage may improve skin patch contact and reduce the likelihood of patch loss.
Now there is a new product on the market that kind of overcomes the limitations of the patches and fulfills the same role, if you like, and it's called Gaviria, and it was launched by Elanco in 2013 for use in dogs only, and it provides analgesia lasting 4 days and consists of a solution that is applied at a dosage of 2.7 milligrams per kilogram topically to the dorsal scapular area. Now this formulation overcomes many of the limitations of the short duration of action of any parenterally administered fentanyl and the unpredictable absorption rates from the patches. It's basically based on a penetration enhancer combined with a rapidly evaporating solvent that when it's applied to the skin, it allows the fentanyl to concentrate on that one spot of the epidermis, and it acts as a reservoir that is going to be releasing fentanyl slowly over time at a constant rate. Now, as you can see from the graph on the right, when it was applied to dogs, the concentrations in plasma were elevated at therapeutic levels for 96 to 120 hours, more or less, in the middle dose, which is what's recommended for use. And I should also point out that the downward portion of the curve is the result of the absorption rather than the elimination. And this is what in pharmacology we call flip-flop kinetics. The absorption is longer than the elimination, and instead of being 6 hours, as you would expect with an intravenous injection, now it's 70 hours. The solution was very safe in all the animal safety studies, and there were 2 special contraindications that were issued. One was not to use in dogs suspected of having paralytic ileus, and in fact when it was administered a second dose, they created a paralytic ileus in some dogs that die from complicated endotoxemia. Now, in animal safety studies, this only occurred at higher doses than therapeutic ones, but it's always a consideration that you always need to keep in mind. Now, the other form of delivery is a constant rate of infusion. And as you can see on this graph, the idea of a constant rate of infusion is to maintain the concentrations in plasma within a therapeutic range. As you can see on this particular example, that was not accomplished when the drug was given as a bolus at similar intervals. There were long periods in which the concentrations were below the therapeutic range. Now, with the constant rate of infusion, you are going to avoid obviously those peaks and valleys, and the idea is to maintain those concentrations in plasma as stable as possible. You might find this good for patients that have pre-existing or persistent medical pain, and you keep them on the intensive care unit. Many of you are probably already using a cocktail of different drugs when you use a constant rate of infusion, and this has a lot of potential benefits, particularly when you combine a local anesthetic like lidocaine, opioids like fentanyl or morphine, and NMDA antagonists like ketamine. And I'm just listing a few of them for as reminder. You're going to attain enhanced analgesia, reduce the individual doses that are needed of each one because they tend to act synergistically. You will reduce the chances of getting opioid tolerance, minimize the development of rebound hyperalgesia, reduce the minimal alveolar concentration, and therefore the risk that you might have when you use high concentrations of isoflurane, so to speak. And with lidocaine, it's particularly been found to have an anti-ileus effect and prevent reperfusion injury. So you'll have less potential for disseminating intravascular coagulation or systemic inflammatory response syndrome. And unfortunately, lidocaine, just like fentanyl, needs to be given as a constant rate of infusion because it's a very short-lived drug, but it's excellent for patients undergoing severe nerve injury like amputations. The constant rate of infusions can be delivered through an intravenous fluid bag with your maintenance fluid, or you can provide it with a syringe pump. And obviously the calculations will differ accordingly, and I'm providing you with a link below if you need assistance doing those punching those numbers. And the loading doses should precede a constant rate of infusion. Otherwise, it will take 3 to 5 half-lives for the drug to reach not steady state, but analgesia. You might already know this one, but it's a very inexpensive tool. An 8-hour cocktail of morphine, lidocaine, and ketamine for a 20-kilogram dog is about $1.50. So it's a pretty resourceful tool that you might consider using in your patients. The last issue I would like to address in relation to fentanyl is this term called the context-sensitive half-time. And it basically refers to the time it takes for the drug to reduce its concentration in plasma by half after a long-term infusion. It does not necessarily coincide with the elimination half-life, and as you can see on this graph, the longer the duration of the infusion, the longer the context-sensitive half-time for drugs like fentanyl or thiopental. And the reason being is that they're so lipophilic that there is going to be now redistribution back from tissues, particularly the adipose tissue, that might hold a lot of the drug, and it took a long time to fill in. So really the half-time now not only depends on the elimination but also on the redistribution of the drug. There is a relative of fentanyl, it's called remifentanil, very similar in everything except on its kinetics. It's broken down by non-specific esterases in most peripheral tissues. It doesn't require the liver or the kidney to be metabolized, and because of this property there is going to be an interesting change in the kinetics of the drug. Doesn't usually happen with most other drugs, and it's kind of shown on this graph here. Remifentanil was given as a constant rate of infusion for 5 minutes to 5 cats, and then it was discontinued, but the concentrations in blood were monitored for 30 minutes. And as you can see, when it was given with the anesthetic isoflurane, the concentrations that were attained in blood were much higher than those in the same animals that were conscious and not given isoflurane, obviously. And this is basically telling us that isoflurane decreases the volume of distribution, and therefore more is sustained in the bloodstream, which makes sense because isoflurane tends to lower the cardiac output and blood perfusion to many organs. So basically there is more remifentanil that is going to stay in blood. However, The elimination half-life stayed the same. It was 16 minutes for cats given isoflurane and 17 minutes without isoflurane. Now, if we consider that the clearance is the volume of distribution times the elimination constant, if we lower the volume of distribution, in order for the elimination from blood to be constant, clearance would also have to decrease. From a physiological standpoint, this is telling us that the tissues that are not being perfused and therefore deprived of remifentanil are also involved in degrading and clearing the drug from blood. And that kind of explains why the elimination from blood is staying the same. So if we were to summarize everything we just said in a nutshell, we could say that fentanyl provides a strong state of analgesia at therapeutic concentrations, but the delivery forms must assure a constant steady state concentrations in plasma due to the short duration of action. Fentanyl redistributes rapidly, but is slowly distributing to all the compartments it can go. Obviously, it has a very long volume of distribution, and it has a very long context-sensitive half-time. By comparison, remifentanil metabolizes very rapidly with tissue esterases. There is no need for the liver or the kidney for metabolism, and it's a context-insensitive drug. I guess this must be the final slide. If you made it this far, I hope you enjoyed the presentation. Just remember not to drink and drive, particularly if with your dog. He may end up needing some of the fentanyl we just talked about. And do not hesitate to contact me if you have any questions. I'm writing my email here, and I wish you all good luck in your practice or whatever your travels may take you. Goodbye.